Today I'm going to discuss about the MRC PCS consultation station, and we're going to talk a bit about the celiac disease. So let's move on with our presentation. So this is your case scenario. 30-year-old individual presents with complaints of chronic diarrhea, bloating, and significant weight loss over the past 6 months. They also report general fatigue and occasional mouth ulcers. Okay, so now this is your scenario, and then you have to, as you know, in the consultation station, you have to take the detailed history and do the relevant physical examination and answer any concerns of the patient. So we'll start with the history. So chief complaints here, the chief complaint is diarrhea. So we're going to ask about the duration of the diarrhea. We want to know about the frequency, consistency, and presence of any blood or mucus. Weight loss, we want to know how much is the weight loss, so amount of the weight loss, then also what was the specific time frame, any related changes in appetite or diet, and the patient also complains of some abdominal pain, so we want to know the location, character, timing, and factors that relieve or exacerbate it. Dietary history is very important. Specifically, we want to know about the gluten consumption, amount and frequency of gluten-containing foods in the diet, any recent changes in the diet, especially if the symptoms improve with gluten avoidance. We're going to ask about the associated symptoms like fatigue, know about the level of tiredness, any relation to meals or specific foods, mouth ulcers, frequency and duration. And this is very important. We want to know about the dermatological or skin rashes or anything. So presence of any skin rashes, especially dermatitis herpetiformis. And this one you must ask, because if you're thinking about celiac disease, so these are actually itchy blisters on the skin. And obviously you want to know a bit more about the gastrointestinal symptoms, about any bloating, about any indigestion, and neurological symptoms as well, tingling or numbness in extremities, or balance issues which could indicate vitamin deficiencies. Then we want to explore a bit about the family history, um, inquire about family members with celiac disease or other autoimmune conditions like type 1 diabetes or thyroid disease, as there is a genetic predisposition. Medical history, any GI diagnosis like IBS, any autoimmune diseases or conditions which are related to malabsorption, and also we want to know a bit about any medication use, especially those that might affect the GI tract or mimic celiac disease symptoms. Social history is important, and we want to know about the alcohol consumption, smoking, and any recreational drug use, as all these can influence symptoms and overall health. And travel history, especially to the areas where GI infections are common, could suggest some alternate diagnosis like giardiasis. Impact on daily life, how symptoms affect diet, and if there's any self-imposed dietary restrictions which improve symptoms, and impact of symptoms on work, school, social activities, and overall quality of life. So this is about that history, and always remember to divide your history into different groups, and then ask the questions which are relevant to the patient symptoms and relevant to your differential diagnosis. Let's move on. Then you have to do the relevant examination. So first of all, going to do the general physical examination to check for any general signs of malnutrition or weight loss, and examine for dermatitis herpetiformis, which is an itchy blistering skin rash, and these are often found on the elbows, on the knees, and buttocks, and look for any signs of anemia. And here you can see this is a typical dermatitis herpetiformis rash, and this is a spot diagnosis. And if the patient gives a relevant history of intensely itchy rash, along with abdominal pain, diarrhea, then you must think about a celiac disease on the top of the list. These are the normal areas where the rash can appear. This rash, normally it is on the extensor surface of the knees, it can be on the elbows and also on the hips or sometimes on the back. So this is very important, and this is actually the rash is actually is a very good sign to elicit in your examination. And if you find the rash, then you can correlate it, and it will be quite easy to come up with a differential diagnosis with the celiac disease on the top of the list. So, general physical examination, we also want to look for any signs of anemia, and then we'll proceed with abdominal examination, assess for any abdominal distension, and palpate for any tenderness which may indicate complications, and a brief neurological examination to check for any neurological manifestations of vitamin deficiencies such as peripheral neuropathy. And this is also a very important relevant examination in the case of celiac disease. So this is all about the examination. So remember, when you have this type of case, always think about why differential diagnosis and do the examination in a systematic manner. So what could be the differential diagnosis? Consider the history. We can think about inflammatory bowel disease. It's got similar symptoms, but usually the differentiating point is blood in the stool, and it can be often diagnosed with a colonoscopy. Another differential which is worth considering is irritable bowel syndrome, but there is no red flags in irritable bowel syndromes like significant weight loss or anemia. Another differential is giardiasis. If the patient got travel history and rapid onset might be differentiated, and usually it is diagnosed with a stool test. Chronic pancreatitis was considered if there is a history of an alcohol misuse or other risk factors, and steatorrhea might be a common feature. Small intestinal bacterial overgrowth overlaps symptomatically but has a different treatment approach. So these are all the differential diagnoses. If you can memorize 3 or 4, it should be enough. What about the diagnosis? If we are thinking online of the celiac disease, so the initial steps actually involves the serological testing, which is actually sensitive and specific for detecting celiac disease in patient consuming a gluten-free diet. So some antibodies, you must remember, anti-tissue transglutaminase antibodies. These are the most sensitive and specific tests, and usually the first choice. So positive tests usually suggest a celiac disease, especially when symptoms and clinical findings are consistent with the diagnosis. Endomycin antibodies, these are highly specific for celiac disease and often used to confirm positive anti-tissue transglutaminase antibodies results, particularly if there is an equivocal cases. Total serum IgA, this is usually done to check for any IgA deficiency, which could lead to false negative transglutaminase antibodies. Patient with IgA deficiency may be tested for IgA-based antibodies instead, like tissue transglutaminase hemoglobin G and DGP IgG. Deamidated glycated peptide antibodies, these can be useful in cases where there is suspicion of IgA deficiency or in children under 2 years of age. So these are all the serological tests. So remember these 3 antibodies, and also remember about the total serum IgA. Genetic testing. While it is not routinely performed for diagnosis celiac disease, but genetic testing for HLA-DQ2 and DQ8 genotyping, it can be useful in excluding the diagnosis in doubtful cases, because as if this absence of these make the celiac disease highly unlikely. But remember, if they are present, it's not diagnostic. So, as they are also found in a significant proportion of general population. Endoscopy with duodenal biopsy, it is indicated if the serology is positive or in the presence of suggestive symptoms with negative serology. So endoscopy obviously allows for direct visualization of the small intestine. So we may have some mucosal fissures or atrophy. And duodenal biopsy will be showing the villus atrophy or crypt hyperplasia and increase intraepithelial lymphocytes. These actually confirm the diagnosis. Multiple biopsies from different parts of the duodenum and jejunum are recommended to avoid missing patchy areas of involvement. So divide your diagnostic approach into groups. First group is serological testing. The second one is genotyping. Third is like endoscopy and duodenal biopsy. Okay, and then nutritional disease assessment. This is number 4. Because malabsorption is a key feature of celiac disease, so we want to know about the CBC to check for any anemia, which can be because of the iron deficiency, folate or vitamin B deficiencies. And BMD, which is bone mineral density, may be considered to assess for any osteopenia or any osteoporosis, which may occur due to calcium and vitamin malabsorption. And finally, response to gluten-free diet. So monitoring the patient response to a gluten-free diet, both clinically and serologically, is an important part of the diagnostic and management process. If there's improvement in symptoms and general health following the initiation of gluten-free diet, it supports the diagnosis. And serological follow-up, a decline in antibody levels after starting a gluten-free diet further confirms the diagnosis and helps in monitoring the dietary compliance. So remember, these are all the tests. So I have briefly put the case presentation here. Once you have done your examination and you've taken your history, you've done your examination, then you have to present the case. So this is just one of the example. Everybody can have their own style of case presentation. So my recommendation is to usually start with the whatever information was given to you. So after a thorough clinical examination and review of the patient history, the clinical presentation raises a suspicion of celiac disease. Then you just mention about symptoms. The patient symptoms of chronic diarrhea, bloating, significant weight loss, fatigue, and mouth ulcers, coupled with examination findings suggestive of malnutrition, prompt further investigations to confirm the diagnosis. The differential diagnoses include inflammatory bowel disease, irritable bowel syndrome, giardiasis, chronic pancreatitis, and small intestinal bacterial overgrowth, which need to be considered and ruled out through appropriate investigations. You not stop here, and you will move on to the investigation. So given the clinical suspicion of celiac disease, I would recommend serological testing for anti-tissue glutaminase antibodies and anti-endomyocin antibodies, and initial screening tests. If these tests are positive, an upper GI endoscopy with duodenal biopsy is warranted to confirm the diagnosis by demonstrating the characteristic histopathological features of celiac disease like villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes. So remember that we have to do the serology first, and if it is positive, then we move on to the next step. Management would involve a multidisciplinary approach, which include a referral to the dietitian and for strict gluten-free diet, which is actually the cornerstone of the treatment for celiac disease, and additional support for symptom management, nutritional supplement to correct deficiencies, and monitoring for potential complications of celiac disease also be essential part of comprehensive patient care. So this is actually a lot actually. You can always modify it, But remember, always when you do the presentation, start with the patient history, then you give an idea about your positive findings in the examination and also important negatives, and then you'll suggest some investigation approach and briefly about the management. So let's move on and see what are the common questions which could be asked in this case. So one of the questions which could be is, what are the key features in the history that suggest celiac disease? So the key features in the history include chronic diarrhea, weight loss, abdominal bloating, fatigue, and mouth ulcers. A dietary history revealing symptom improvement with gluten avoidance would also be suggested. What physical findings might you expect in a patient with celiac disease? So with this one, we have already discussed that the findings might include signs of some malnutrition or weight loss, dermatitis herpetiformis we saw in this patient, and possibly signs of anemia. Abdominal examination might reveal distension, but is often unremarkable. Investigations you will perform, again the repetitions. So initially we do the serological tests like IgA anti-tissue transglutaminase antibody and IgA endomysial antibodies. So in case of if the patient has IgA deficiency, then IgG version of these tests are deamidated gliadin peptide, DGP antibodies, these may be used. If serological tests suggest celiac disease, then we move on and do the upper GI endoscopy along with the duodenal biopsy is recommended to confirm the diagnosis by identifying the characteristic histopathological changes. Differential diagnosis we already discussed. We will be thinking about inflammatory bowel disease, irritable bowel syndrome, infectious gastroenteritis, small intestinal bacterial overgrowth, and chronic pancreatitis. How would you differentiate celiac disease from irritable bowel syndrome? While these both symptoms can present with similar GI symptoms, celiac disease is associated with specific serological markers and histological findings, histopathological findings on biopsy, as well as improvement in the gluten-free diet. IBS diagnosis is often made on the clinical criteria after excluding other causes, as there are no specific diagnostic tests. How would you manage a patient diagnosed with celiac disease? So management involves a lifelong, strict gluten-free diet, which could lead to symptom improvement and healing of intestinal mucosa. So referral to a dietitian who is experienced in managing celiac disease is crucial, and patient should be monitored for nutritional deficiencies and advice and supplementation if necessary. And follow-up obviously is needed to assess the dietary adherence and symptom resolution. Complications, well, long-term complications include osteoporosis, iron deficiency anemia, vitamin and mineral deficiencies, and there is also increased risk of intestinal cancers and development of other autoimmune disorders. So what advice normally would you give to a patient newly diagnosed with celiac disease? So we're going to educate the patient about the importance of adhering to a strict gluten-free diet, and this is a cornerstone of management, and discuss potential source of gluten in diet, cross-contamination risk, and the need for reading the food labels carefully. Also advise on joining the patient support groups and utilizing resources for celiac disease organizations. How do you monitor the patient progress? So monitoring usually involves assessing the symptoms, resolution, dietary adherence, and improvement in the serological markers. Repeat duodenal biopsy, well, it might be considered in cases where symptoms persist despite dietary adherence. Regular follow-up to monitor for complications or associated conditions is also recommended. Why it is important not to start gluten-free diet before completing the diagnostic test? Well, starting a gluten-free diet before testing can lead to a false negative results on serological test and duodenal biopsies. So it complicates the diagnosis. For accurate diagnostic testing, it is crucial that the patient continues to consume a diet containing gluten. So if already patient has stopped taking gluten in the diet, then we usually recommend the patient to continue with taking gluten so that we can avoid these false negative results. Genetic testing, what is the role? HLA-DQ2 and DQ8, these can support a diagnosis of celiac disease. So normally nearly all patients with the condition carry one or both genes. But these genes are also present in about 30 to 40% of general populations. So it is more useful in excluding the diagnosis in doubtful cases. How would you differentiate celiac disease from Crohn's disease? Whereas Crohn's disease, it can affect any part of the GI and often present with abdominal pain, weight loss, and sometimes bloody diarrhea. Imaging studies, colonoscopy with biopsy, revealing obviously there's a different thing. Crohn's disease, we will see the transmural inflammations and granulomas. It can help differentiate Crohn's disease from celiac disease. Celiac disease is primarily affects the proximal small intestine and is diagnosed through serology and duodenal biopsy showing villus atrophy. While Crohn's disease we already have discussed, it can affect any part of the GI tract. And celiac disease is more normally it is proximal small intestine. Can celiac disease present later in life? Well, it can present at any age. Okay. So it can be triggered or become apparent for first time in adults by factors like any surgery, pregnancy, childbirth, viral infections, or even the emotional stress. What nutritional deficiencies are common in celiac disease? I think we already discussed. Common deficiencies include iron, calcium, vitamin D, folate, and vitamin B12 because of the malabsorption in the damaged small intestine. So management obviously involved, we have to give some supplements and ensuring a balanced diet. Also remember to monitor the bone density because osteoporosis can be a complication. Some associated autoimmune disorders seen with celiac disease. Well, there is a risk of other autoimmune disorders, including the type 1 diabetes, autoimmune thyroid disease like Hashimoto's thyroiditis and Graves' disease, autoimmune liver disease, and Addison disease. So normally, how do you follow up with the patient after initiating a gluten-free diet? So follow-up involves the evaluating symptoms, again repetitions, and dietary adherence and monitoring for the nutritional deficiencies. So we usually repeat the serological test after 6 to 12 months after diet initiation to assess the serological response. And ongoing follow-up, it includes annual health checks to monitor for potential complications or the development of associated condition. And patient education is crucial for managing the celiac disease, and patient need to understand which food contains gluten, how to read the food labels, and how to avoid cross-contamination in the kitchen. They should be aware of the importance of adhering to gluten-free diet to prevent complications and improve the quality of life. So that's all about the celiac disease. Hopefully this presentation will help you in preparation for your MRCP PCS exam. So one of the candidate told me they got this case, and the rash was quite typical and the history, so they were able to correlate it, and the case went very well. So remember this rash, dermatitis herpetiformis, and its correlation. Thank you very much, and I'll see you in my next presentation.